Hello friends, now I will be continuing about seizure disorder. In my first lecture on seizure disorder, I discussed what is seizures and I also explained to you that is seizure is not same as epilepsy and it's not same as convulsion. And I also discussed different type of seizures in the previous lectures. So today I'll continue with seizures, and the first thing today I'll talk to you regarding certain syndromes associated with seizures. The first is Lennox-Gastaut syndrome. Now in this, classically it is seen in children, and the features are multiple seizures type. That means the patient may have generalized tonic-clonic seizures. Patient may have absence seizures. Patient may have atypical absence seizures. So in one patient can manifest different type of seizures, so-called multiple seizures type. Second, EEG is classically less than 3 hertz per second. I hope if you can recall, in absence seizure it was 3 per second, but here it's less than 3 per second. And third is impaired cognitive function. That means patient has associated mental retardation. Okay, in fact these three are known as triad of Lennox-Gastaut syndrome. Okay, and in Lennox-Gastaut the usual causes which predispose to this condition are birth injuries, like hypoxia, okay, perinatal asphyxia. All these are the usual cause which predispose to Lennox-Gastaut syndrome. Second is juvenile. Second type is juvenile myoclonic seizures. It classically is seen in children. And as I discussed last time, these children, they develop shock-like movement. Involving one limb or one half of the body or the whole body. If you can see, just like shock-like sensation, and it typically occurs when the patient gets up in the morning time. Sleep deprivation is a very important precipitating factor, and these patients respond very well to valproate therapy. Now the third thing is mesial temporal lobe epilepsy. Point to be noted, this is mesial. Remember, when you discuss about complex partial seizure, that is also known as temporal lobe seizure, but this is mesial temporal lobe epilepsy. What the classical feature of this? In this, there is hippocampal sclerosis. As hippocampal sclerosis, that's why these patients do not respond to drug therapy. That is AED. AED stands for anti-epileptic drug. They do not respond to anti-epileptic drug, but they respond very well to surgery. Okay, and in fact, this is a very frequently exam question. Very frequently exam questions, right? So this patient you treat by surgery and juvenile, and as far as Lennox-Gastaut syndrome, you treat by, the new drug is rufinamide. For Lennox-Gastaut syndrome, rufinamide is a new drug. And juvenile myoclonic, they respond very well to valproate. Now we talk about difference between syncope. How to understand, whenever you are being talked or asked about epilepsy, unless proved otherwise, they are talking about generalized tonic-clonic seizures. So let's talk about difference between syncope and generalized tonic-clonic seizure. Syncope. Generalized tonic-clonic seizures. Position. It always occurs in standing position, but this may occur in any position. Number two, loss of postural control. Loss of postural control. Yes, this occurs in both. But in syncope, the patient going into unconsciousness, time of going into unconsciousness, few seconds, it is immediately. Then duration of unconsciousness. Again, few seconds only. It is for hours. For hours. It is only few seconds. Few seconds. Here it is. It's for hours. Return to consciousness. In few seconds. Again, it takes hours before patient become conscious. Next, tongue bite. No, very often. Then micturition. During the attack? No. Yes. Okay, so this is how we differentiate syncope from generalized tonic-clonic seizures, right? So patient has come where we are suspecting patient to have epilepsy. Most of the time we may get history, but at time you do not get history. Then what are the features which strongly point toward generalized tonic-clonic seizures? Tongue bite. Is one of the classical feature of generalized tonic-clonic seizure. If patient is unconscious and he has a tongue bite and a bleeding tongue, is almost virtually diagnostic of generalized tonic-clonic seizure. Here I like to tell you is something special about tongue. There are certain unique thing about this great organ so-called tongue. First of all, tongue is a purely muscle. That means there are no bones. Second thing, tongue is surrounded by 32 teeth. Tongue is the one organ which is almost constantly moving, especially when we are speaking, eating, talking. When talking, speaking, or eating, it keep on moving. It is a highly always moving. But still, in spite of that, tongue bite does not occur in a normal person. This thing you may not have never noticed till now, if I'm not wrong, but now you'll appreciate that. Like you talk, I talk, tongue is moving and surrounded by 32 teeth, but tongue bite does not occur in a normal person. So, tongue bite does not occur in a normal person. That's why I say altered sensorium patient with a tongue bite is almost the diagnostic of epilepsy. Okay. Well, patient has come to us for the first time with epilepsy, with a history of seizure. First time seizure. Should we label this as a case of seizure disorder or epilepsy? No. Why? Because first of all, you have to rule out so-called pseudo-seizures. Pseudo-seizure. What do you mean by pseudo-seizure? There are many conditions where patient may develop seizure, but not due to actually some brain problem. Now, what are the conditions where we can have pseudo-seizures? Like hypoxia, low glucose, hypoglycemia, low calcium, hyponatremia, then hyponatremia. Then we talk about certain subdural hematoma, drug toxicities, especially many drugs like aminophylline. Okay, so there are many things which can produce seizure-like activity, but we do not label them as seizure-like. Suppose a patient of hyponatremia is there, and in hyponatremia, patient can have some sort of convulsion activity, but we don't label them as a case of seizure disorder. That means they all constitute what called pseudo-seizure. So friends, before we diagnose a case of seizure disorder, all these things should be ruled out. Okay, of course, all of us know the single most important investigation for a seizure disorder is EEG. But before we go for seizure disorder, all these should be ruled out. So now let's see what are the investigation before you go for EEG. So investigation that you need to do is before EEG is investigation, complete blood count, then urine examination, glucose level, electrolyte, especially sodium. Remember, potassium usually causes cardiac problem, both hypo and hyperkalemia. But it is hyponatremia which causes seizure disorder. So we like to go for seizure disorder. You like to go for kidney function tests because patient may have uremia, may come as seizure disorder, and unless you treat the uremia, seizure will not go. Similarly, LFT, hepatic encephalopathy can come as seizure disorder. You have to treat the hepatic encephalopathy. You have to rule out any toxic thing. Toxicology. Toxic thing means like aminophylline toxicity can lead to seizure disorder. And of course, you like to go for CT or MRI to rule out condition like subdural hematoma. So remember, all these investigations are done to rule out pseudo-seizures. Okay? So once, if there are nothing of this sort of there, then the single best initial investigation is best initial investigation for epilepsy is EEG. Because EEG is the one which is going to record directly the disturbed electrical activity of the seizure disorder. I hope you remember the definition of seizure is a disturbed electrical activity of the brain is seizure. So EEG will confirm the diagnosis. Now what is the importance of doing EEG? It will confirm the diagnosis, whether patient has epilepsy or not. It will also confirm type of seizures. Type of seizures. What type of seizure patient has, because different seizure have different type of recording is there, right? But remember, but there are few false positive, false negative. In around maybe false negative. That means patient has epilepsy, but EEG is normal, is so-called 10% is false positive, is false negative. False negative is around 10%. Again, repeating second time, patient has actual in seizure, but EEG is normal. But in 5% cases, it may be false positive. Means patient does not have seizure, but still EEG may show some abnormality. Okay? But still, it is always the investigation of choice. Because as I told you, tell you type, confirm, and of course, confirm type of seizure also. Now, suppose patient is taking anti-epileptic drug, and if the patient remains symptom-free for 3 years, then we can gradually withdraw the medication. Then before you withdraw, remember, we have given the treatment for 3 years, and patient is symptom-free for 3 years, and we plan to withdraw anti-epileptic drug. Before we withdraw, you do EEG. EEG. Now, at 3 years, EEG may be normal or it may be abnormal. But remember, patient remains symptom-free for 3 years. Now, abnormal EEG, should we withdraw or not? Yes, we can withdraw. We can. So abnormal EEG at the end of 3 years is not a contraindication to stop it. You can stop anti-epileptic drug, but remember, anti-epileptic drug is always withdrawn very slowly over a period of 3 to 6 months. But recurrence is more common in these patients as compared to those patients where the EEG was normal. Okay, so again, repeating second time, at 3 years of symptom free, EEG abnormal is not a contraindication to withdrawal. So in the next lecture, I'll be talking to you regarding treatment of epilepsy, treatment of status epilepticus, and of course, I'll be talking to you regarding many newer drugs for epilepsy. Again, friends, I have recorded many lectures previously also, which are there in YouTube. You can see. And if you want to see any particular topic, don't hesitate to send me message by messenger. Thank you very much for watching this video. And in the next lecture, I'll be talking to you regarding treatment of epilepsy. Thanks again. Thank you very much.